Okay, at 5:31, I will welcome everyone to the 28th convening of the Alameda County COVID-19 Community Advisory Group. And want to remind folks that we have interpretation in Spanish available, which I will turn on shortly. If I could ask one of our interpreters just to give a welcome and remind people that the function is there.
Absolutely. Hola, ¿qué tal? Buenas tardes a todas las personas que están en esta junta de la Agencia de Servicios de Cuidado de la Salud del Condado de Alameda. Para las personas que necesitan interpretación en español, por favor, cerciórese de hacerle un clic en el globito que aparece en la parte baja de su pantalla y seleccione la opción de español. Muy amables. Gracias. Back to you, Lauren.
Thank you. I will start it now. Okay, so we ask everyone to please select their language. We have English and Spanish, and also want to remind folks we have closed captioning available. You can turn that on. And finally, we have live interpretation also in ASL, and we'll have people interpreting there. The final reminder is to speak slowly for our interpreters and to mute your mic when you're not speaking. And with that, I will turn it over to our Public Health Director, Kimmy Watkins-Tart.
Welcome. Happy that you all are here tonight. And so we are, looking forward to hearing from our youth leaders from Umoja Youth Mobilizers, as well as some county updates and division updates. And in particular tonight, we're going to spend some time talking about the final results of our work together around strategic refresh or strategic planning. You all have been phenomenal partners in that work to help us really think about how we move forward and what our strategy should be for the next couple of years. And so again, want to welcome you to the space. Thank you so much for your partnership, and want to turn it to my co-chair, Nestor Castillo, who I believe is facilitating tonight.
Yes, thank you, Director Kimmy Watkins-Tart, and just like to welcome everyone. And our other co-chair, Greg Hodge, is actually out tonight, and so just wanted to give everyone a warm welcome on behalf of the co-chairs, and thank you again for your participation. Before we, so this is what the agenda looks like tonight. Wanted to remind everyone that, when you are not speaking, to put yourself on mute. And if you happen to be joining us, if you're new in this space, that you can, alongside your name, add your organization, the organization or the constituents you're representing. And it does sound like we have someone who is not muted. So if you could please mute yourself if you can. And any comments or questions on the agenda? Is there anything burning before we turn it over to our Umoja Youth Mobilizers? Let me make sure that I don't see any hands here. Okay, so all right. So in that case, we're going to turn it over to our partner updates and get a sense of what is happening on the ground. I think Saher, you're going to be presenting on behalf of Umoja, and maybe Susanna as well.
Hi, yes, thank you so much. Hello, everybody. I'm going to be presenting. Can Susanna share her screen?
Yes, I'm sharing right now.
Okay, great. Hello, everybody. Hello, CAG members. My name is Saher Khan. I am one of the co-leads for the Oakland Umoja Health Youth Mobilizer program. And then I'm going to have my other presenters introduce themselves.
Hi, everyone. My name is Susanna. I'm the other co-lead for the Youth Mobilizers program. And I'll turn my camera on for a second, but I'll pass it on to Darius to introduce himself.
Hello, my name is Darius. I'm also a youth mobilizer and a student at Laney College.
So the Youth Mobilizers are a team of college students and graduates who are part of the larger Umoja Health workforce. Our youth leaders help to promote vaccine awareness and uptake in 18 to 30-year-old residents of Alameda County. And we do this by collecting data on vaccine attitudes and then using this data to create effective public health messages. Can we go to the next slide? Okay, so over the past couple months, we've targeted the unhoused and unsheltered community because we feel that this is a population that is not only underserved, but is also at an unusually high risk for being affected by COVID-19 and seeing adverse effects from living unsheltered in a country that is in a state of a national pandemic. So we created hygiene kits to hand out, which allowed us to simultaneously offer support and resources while also collecting data through a tailored survey. We visited youth shelters in Alameda County. Some of the shelters we visited were East Oakland Community Project, Covenant House, St. Mary's, which is a senior center. So we did not include their data in the surveys, but we did them on paper. And then we also visited some encampments in the surrounding Oakland area. So the survey is created by our youth mobilizers in efforts to identify Alameda County's low-income sheltered residents' attitudes surrounding the state of COVID-19 and where we are in the pandemics today. All the data is collected anonymously, and it's used to help inform public health leaders about what resources are needed for when the next wave of COVID sets in. So we have a total response of 103 over our 2 surveys. The numbers are rounded up. So I'm just going to give you some demographics from our surveys. Gender-wise, 63% of our respondents are male, 31% are female, 2% non-binary, and the rest decline to state. Race, 71% are Black African-American, 7% Hispanic, 2% identified as Caucasian or white, and then 2% identified as Asian or Pacific Islander, and then 9% identified as mixed race, and the rest chose not to state. Age, 48% were 10 to 24, which is the majority of the population that we're trying to reach, so that's good. And then 11% were 25 to 34, 11% were, the rest of the 11% were older than that. And then zip code, mainly Alameda County, Oakland. Some of the zip codes that were very popular were 94605, 94612. You can go to the next slide.
Let me unshare for a second.
I can read out your slides too if you want.
Oh, no, it's okay. See if I can. Okay. So can you guys see the screen?
Yeah.
Okay, good. Okay, so hi everyone. Again, my name is Susanna, and these are some of the pictures that we took during our Hygiene Kit Handout. So to the left is a picture of the items that we have in the bag, including masks, snacks, water, Tylenol, hand sanitizer, and our FAQ card, which has a QR code to our link tree where you can find videos on COVID-19. We make different bags for males and females that are tailored to their specific needs. The rest are pictures of us making the bags and handing them out in the community. And now I will pass it on to Darius to speak on his experience sharing out or handing out the hygiene kits in the community.
Thank you, Susanna. The Umoja hygiene kits have benefited our community by providing resources, including snacks, hand sanitizer, water, COVID tests, and more. We, the youth mobilizers, have distributed these hygiene kits to shelter homes and homeless encampments where we found people that genuinely appreciated our efforts in bringing these resources in exchange for a quick survey. This survey, created by us, provided data based on everyone's own unique experience of going through the pandemic. From this survey, we have learned if the participants will continue wearing masks in crowds, have access to rapid tests, high quality masks, and if they or a family member has ever tested positive for COVID, and their general outlook of the virus. Overall, I believe that this survey was very helpful in learning the many perspectives of the community and how they differ from one another.
Thank you, Darius. See if I can, okay. So thank you. Now let's look at the data from the surveys. Here are a few questions that we thought were important to highlight. Of the people that responded to our survey, 80% were vaccinated, 17% were not, and the rest declined to stay. Of the population that was vaccinated, 32% have been boosted, while 62% have not. During that time that we took the survey, it indicated to us that after receiving their initial dose, most people were less likely to go back to receive their booster dose. And some of the other questions on our survey mirror the questions that we have on the Umoja's attitude survey. That survey is a bit longer, but we asked how people think COVID is being spread, because we feel that it is important for them to understand how the virus is being spread in order for them to protect themselves from it. The choices included airborne, on surface, on people's hand, in large crowds, and all of the above, among other options. We can see here that a majority of the respondents, almost 50%, answered all of the above to the question, but 31% answered airborne, which was the correct answer. In the final question, we asked the survey respondents what their biggest concern surrounding the COVID-19 virus is, and the COVID-19 vaccine and the COVID-19 pandemic overall. These to the right are some of the answers that we received. Some people said that they're worried about what the makeup of the virus is in the vaccine. Some were worried about the long-term effects after infection with the COVID-19 virus. Some asked, why is this happening? How is it going to affect our life going forward? And when is it going to end? Some were questioning, why is the government not being honest? Why isn't the mask mandate being enforced? And others had concern about families losing housing, people losing their jobs, and they weren't necessarily sure how to find resources during this time.
Okay, I'm now gonna just summarize some of the recommendations that we came up with up to this point based on the data from our surveys and the social media aspect of our work. Using social media platforms, our first recommendation is to build trust and strengthen relationships within the community. If Umoja has a good relationship with community members, such that they associate us with positive interactions, like winning a raffle or for a gift card through an Instagram poll, or commenting and sharing a TikTok that made them smile, they'll be more likely to trust health organizations in times of need. For example, when we want people to comply with masking mandates, they'll be more likely to follow our recommendations. Our second recommendation is going beyond a vaccine only approach. We're in a pandemic, and although vaccination is very important, we feel that when you approach the community with a I want to help you in any way that you need mindset, they're more willing to accept the help and follow our advice. For example, this is what we're trying to do with the hygiene kits, by providing basic resources. Some of our current slogans are fight back at vax, spread the word, not the virus, hashtag Umoja Help. We want to create messages that resonate with our target audience, which is youth between 18 and 30. And then we're going to share with you a quick TikTok that we made On October 1st, Umoja had its second annual anniversary health fair, and there was a lot of vendors, local organizations, free tacos, live music. And so here's a short TikTok that was made by the youth mobilizers covering that event.
Okay, let me know if, I might have to disconnect from my AirPods.
I can't hear it.
Okay, let me just reload the video.
With me to UMOJE's second anniversary fair at Lake Merritt.
Hello, Maria.
I think there's like background noise. That's okay.
What's that? Thank you for watching, and please join us at our next event.
Okay, so this,
UMOJE's
pause it. The sound didn't go through that well. So when you actually play the TikTok, there's none of that background noise. It's just the music. But it's just one of the TikToks we made. We wanted to share with you guys. And then lastly,
what did you bring into me?
Just a quick reminder to mute yourself. Thank you.
yeah, you can go to the next slide. This is our last slide. We just want to invite you lastly to our third annual COVID Forum. It's a chance for young people to have open, honest discussions about COVID-19, about the pandemic, the vaccine. It's a safe space for youth to share how they've been feeling over the past 2 years. The tentative date for our forum is November 1st. However, we're still planning with Oakland Unified School District to finalize time and location. We just wanted to extend an early invite. So if you know anyone who would be interested in attending or even participating in something like this, please let us know in the chat. And that's all that we have for you today. Those are our updates, some things we've been working on. Please follow us on our social media. And if Susanna or Darius doesn't have anything to add, then we'll take questions if you guys have any.
Yes, just join us on our next events. But thank you for having us.
All right, thank you so much, Umoja Youth. Do we have any questions for them? There is a question in the chat asking if you could share the TikTok link.
Yes.
And then also if you could email about the forum. Yes, if you can actually make the flyer available for all of the CAG participants, that would be great.
I will do that. I'll send it out to the CAG participants once we have all the finalized info. Is that better? And then I'll go ahead and share the TikTok in the chat.
Excellent. Any other questions?
There's also a request to send the survey results, if you wouldn't mind. It's really interesting.
We can do that. We can share the Google form and you can just look at all the survey results.
Be great. Thank you.
Okay, well, thank you so much for all of that information. It was super informative and excellent work that you all are doing. I'm actually really excited by some of that information you presented and thinking about how the work can be adjusted and meet the needs of folks who we're hoping to serve. Next on the agenda, we have our, well, unless I think we have at least a couple minutes to do, if there are any other partner updates before we move on to the agenda. Does anyone else want to quickly, in 5 minutes or less, do a report out on anything else that is that you all are learning on the ground, or any updates regarding your work? I know we have a smaller group tonight, but I want to make sure that I'm not missing out on anyone who might want to give an update. Okay, well, why don't we turn it over then to our folks over at the county to get a little bit of an update on what's changed with Mpox and COVID data. I think I will go to Dr. Dunn first. Is that correct?
Hi, everybody.
Hi, Dr. Dunn.
Next slide. Oh, I think
Oh, maybe not. Okay.
No problem. I'll pass
Sorry.
it back to.
No, let me. I think what we can do is. My apologies. I'll get to those slides. You're here. You're on. Let's go.
Awesome. Thank you. Hi, everybody. I'm going to provide a very brief monkeypox or Mpox outbreak update. Next slide, please. So for Alameda County, Mpox cases are a total of 233. And as reported before in this forum, the cases are mostly young people, mostly male, and most are gay or bisexual men, although it's important to note that anyone can get Mpox after an exposure. 40% of persons with Mpox are Hispanic, Latinx, and 25% Black, African American, 21% white, and 9% Asian. 63% of persons with Mpox live in Oakland, and 27% are people living with HIV. And on the right, you can see the Mpox cases by test date for Alameda County. This curve or epicurve is important to note that there was a peak in the early part of August. And then later here, you can see in the most recently, there's been a decrease in the number of monkeypox cases in Alameda County. This has also been found in other settings throughout California and in the United States. Next slide, please. We've recently updated our Mpox vaccine eligibility. This is on our website. We wanted to share this. These are the current recommended groups to receive Mpox vaccine. And this is a reflection in the changes of the epidemic, as well as the need to reach additional persons for prevention with Mpox vaccine. And you can find these also on our website. Next slide, please. I wanted to report a little bit about Mpox vaccine updates for Alameda County residents. Over 9,000 Alameda County residents have received Jynneos vaccine. And this table describes the race ethnicity for those that have received the vaccine in Alameda County. And as noted, most are white and 18% Latinx and 12% Black or African American. And I would point you to the disparity between the cases, proportion of cases that are Hispanic, Latinx, and Black and African American, and those that we've reached to vaccine. Next slide, please. So our Empox priorities going forward are a reflection of the need to continue to reach to communities with vaccine. We're working with community partners to reach young gay and bisexual men of color and their sex partners to ensure they have good knowledge of Mpox and sexual health, as well as vaccine access. And our efforts are working to reach to communities through clubs, bars, balls, and high school LGBTQ clubs. We are also sharing on the importance of completing the vaccine series. The vaccine is 2 doses, so it's important to complete the vaccine series. We are considering and have expanded vaccine eligibility criteria. So this is a very recent update that I presented earlier. We are continuing to partnership with the LGBTQ Center on our community activities and all of our activities going forward. And we are continuing to identify cases and do contact tracing. We are ensuring our guidance on Alameda is up to date on our Alameda County website. and with a real focus on countering misinformation. For example, we had learned that some persons were reporting that intradermal vaccination was less efficacious, and we have provided updated materials and information to ensure that it's clear that intradermal administration of the vaccine is equally potent to subcutaneous administration. Next slide, please. Thank you. That's all for me. Thank you.
Right. Were there any questions on that before we let you go, Dr. Dunn? Make sure that we have a chance to
difference in opinion.
Raise questions.
And so she definitely like major.
And someone is not muted. Any questions for Dr. Dunn before we move on? Okay. Thank you, Dr. Dunn. I think now we're going to turn to, is this you, Dr. Moss? Or is it?
I think so, but I think we have to rewind the slides a little bit.
Gotcha.
There you go.
We have a quiet group tonight.
I'm gonna, I'll do my thing and then we'll see what happens. We are, so this is our daily reported COVID cases going back to the peak of the summer wave. And you can see sort of a really kind of a plateau, maybe still a little bit of slow decline in recent weeks. Next slide. And hospitalizations actually have continued to decline. We're down around 50 people in the hospital. Not all-time lows for the pandemic, but certainly much better than they were. Next slide, please. So wastewater data, because our case reports don't capture, lots of infections, we also look at the wastewater data on actually what I have is a little conflicting right now. On the left is the East Bay Mud data that the California Department of Public Health does the analysis. And you can see the most recent data point is up a bit. Now this data can be noisy, so try not to let one data point sway us one way or the other, but it's notable. And then BioBot is a federally funded national program, samples wastewater from facilities across the country. I think there's actually an overlap here in terms of wastewater that is sampled, but they use slightly different methodology. They're up through October 5th, still, you can see that period of plateau and then more recently a decline. So I'm just in a wait and see mode on this. I think with COVID, it's a matter of when it goes up, not if, but it's certainly not enough here to say anything is happening. And I will say around the region, wastewater is all pretty reassuring looking. Next slide. I was kind of holding my breath on this. This is COVID data from England. These are COVID hospitalizations, and you can see they've had about 3 weeks of rise. So I think this is more concerning, and often we've seen things hit the United Kingdom before spreading to the Northeast and then the West Coast of the US. So maybe a sign of things to come. Some things that were happening in the Northeast have sort of improved, New York's data, but also COVID data is probably a little less reliable these days. People are testing less and reporting less frequently. And so all that is to say that we probably will see an increase. It's just not quite clear when or how bad it'll be. Next slide. This is another important data point. So these are, this is COVID booster progress by age group. First booster in blue and people who have gone on to get a second booster in yellow. And you can see we do pretty well, particularly for people over 50, but we also have lots of people who have never been boosted at all, and we're going into another winter, and we are expecting more COVID around. So really, we want to get people boosted. It's the most important, I would say, for people over 50, but really the recommendation is for everybody, and people 12 and up are recommended to get that newly available bivalent booster that includes, that is both the original vaccine and also tailored to more closely match what we see circulating now. So let's get people boosted. Now is the time before those cases start going up. Next slide. We also want people to get their flu vaccines. This is flu data from California clinical labs. It's numbers, not dates on the bottom, but what you're seeing is last year's actually relatively mild flu season in California. And then things calmed down over the summer, and now we're just starting to see increases here, a little more pronounced in other parts of the country. We're expecting flu this year. So get your booster, get your flu shot. Next slide, please. A few policy things that I wanted to cover. So this is several weeks ago now, but it happened since our last CAG meeting. The state moved their mask policy to align with CDC. We don't have a separate mask policy here in Alameda County at this time. Mask recommendations are now tied to CDC COVID-19 community levels around the state. Everybody is recommended to mask indoors at high COVID community levels. Vulnerable people are recommended to mask at medium and high community levels. That includes if somebody in your household is at high risk for bad COVID outcomes, even if you're not. Also, the state changed its policy around high-risk congregate settings. So at low community levels, masking now optional in shelters and correctional settings. I'll note that Alameda County operated facilities are still subject to the county facility masking requirement established by the Board of Supervisors. Masking is required in under state policy at medium or high community levels in those shelter and correctional settings, as well as in any clinical areas and during COVID outbreaks. And there are also Cal OSHA rules at play for settings, so employers need to make sure they're aware of what Cal OSHA requires of them. Masks continue to be required by the state in healthcare and long-term care facilities, and they continue to be recommended as part of our exposure and isolation guidance. Next slide, please. I was asked to share on the California COVID-19 supplemental paid sick leave policy. There have been a few different policies and resources available to workers over the course of the pandemic. This has been in place throughout all of 2022 and just got extended. I think it was set to expire at the end of September, but now goes through the end of the year. It provides 80 hours of paid COVID-19 related sick leave. Half of that can be for isolation, quarantine, vaccination related work absences, or child's school closures or childcare disruptions. The remaining 40 hours can only be used for COVID-19 illness. This policy is for employees who are unable to work or telework. It can be applied to both an employee and to when employees are caring for qualified family members with COVID or with one of these other conditions. And importantly, this is only this state policy passed by the legislature is for employers with 26 or more employees. So small employers are not covered by this policy. I've included a link there. We can put it in the chat as well to the FAQs on this. Next slide, please. I just wanted to briefly, we're getting asked a lot about states of emergency right now, so just wanted to comment briefly on the landscape. There are several federal emergency policies in place. There's a national emergency. There is also separately a public health emergency. That is one that has big implications for Medicaid because it made it possible for people to stay in their Medicaid. In California, it's called Medi-Cal coverage without going through some of the regular re-enrollment processes. That is still part of the current public health, federal public health emergency that is probably going to be in place at least until the middle of January because the federal government has said they'll give a 60-day notice when they lift this. There are several other federal large-scale emergency regulations in place. There's a state declaration of emergency that remains in place. And then here in Alameda County, there's a local emergency that was declared by the sheriff and ratified by the board. And then separately, there's a local health emergency that was declared by my predecessor and ratified by the board. Those both remain in effect. Next slide, please. We're asked a lot when this would go away. We are, importantly, we're looking at the state and federal declarations and what's going on with those. I'm also looking at ongoing pandemic conditions, particularly deaths, emerging variants, how they're transmitted, how much severe disease they're causing, treatment access on the ground here, and vaccine booster uptake, all things that we're looking at. Of course, there is a lot of other stuff at play with COVID, but these are some of the major pandemic conditions that we're tracking. And we're also weighing the impact of changes in these policies would have on things like convincing people to get their booster shots, right? We really want to make sure that we're not doing anything to sort of work against our efforts to get county residents as prepared as possible for the winter wave that is likely going to be here soon. We have not set pre-specified metrics. We know from experience, COVID metrics improve very dramatically between waves. They get better, they get worse again. So that makes it complicated to use some of those routine metrics as thresholds. Also, emerging variants make it hard to use metric thresholds to assess risk. And we want to have some flexibility given really a wide range of possibilities with what's happening around us at state and federal levels with these declarations and potential for all kinds of messaging confusion as we've seen before with COVID. Next slide. So I think what we're sort of looking at going forward, eventually all of the remaining COVID policies are probably going to go through some change. So I think people should expect continued rollback at the state, federal, and local level, as we have seen really since very early on in the pandemic, this process. At the same time, we're going to see infections rise again in the coming months. Certainly, I would be very surprised if we didn't see that this winter and perhaps beyond. And we're going to continue to see the types of impacts we've seen. Hopefully, the trend to less severe disease per infection, but again, hard to know for certain. I expect that the underlying drivers of COVID and other health disparities remain in place, and we would expect those to continue to impact our communities this winter and beyond. And so the challenge is really how do we support our most impacted residents to get through this this transition period. and to continue to support our public health efforts through that. I think that's my last slide. Yeah, so one other thing I'll add, I wanted to spend some time on isolation, COVID isolation policy tonight. We don't really have time for that, but I just wanted to keep it on the CAG's radar as another policy area that we're sort of looking at. Isolation guidelines have not changed. Our policy matches state and federal guidelines for the most part, and that's not expected to change dramatically going into the winter. That's it.
All right, thank you, Dr. Moss. Do we have any questions?
Well, I'll.
No questions?
It's a good night for it. We got a sick kid in the house. So far, it doesn't appear to be COVID. So I'm going to step off, but hopefully one of my colleagues can ping me if I need to jump back on and help answer some questions. And I'll put a link in the chat to that state sick leave policy FAQ.
Okay.
Thank you, Dr. Moss. All right. In that case, I think we'll turn it over to Julie. Are you up, Julie?
I think so. Yes.
Okay.
Great. All right. Well, welcome. Good evening, everyone. Thank you for being here. If you could go to the next slide. As Director Watkins-Tart mentioned earlier, we're going to spend just a little bit of time going over. We have moving into the very last stage of putting together our 2-year COVID-19 strategy. And for those folks who are new or who have not participated in this so far, just to remind you of the process that we've been through, that last May, we started to engage the CAG in looking at our activities and to get your feedback on how to direct future activities for the next couple of years. Between June and now, we've had a number of CAG meetings. I just wanted to mention in July, this has been pushed back a month. In July, we focused on monkeypox, a little surprise epidemic in the middle of all of this. And so this month, basically, we've collected over several sessions your feedback. We've incorporated that into our strategic plan. And as of at this point, we have an updated strategy. So I'm very excited. I'll be presenting to you what has changed from the last one. Before we dive into that, though, last part of our process has been to get feedback from you. We've summarized it, sort of synthesized it down and presented it back to you to make sure that we're on track and that we're hearing the things that are really important coming from you. So if we could go to the next slide. Last month, we broke into small groups, and specifically because there is a new bivalent booster that just came out, we wanted to get your feedback on what you're hearing from the community and what people are saying about this, if there's concerns or what the issues were. And so here's what we heard from you from last month, that basically the issues that our communities or your communities have been lifting up are issues around safety, wondering if this new bivalent booster is safe to do both with the flu and that together. It seems that there's been some erosion of trust, and part of that is linked to the fact that the vaccines have not ended the pandemic. Thinking back 2.5 years ago, we all thought after the vaccines came out, this would be over, but COVID has been a very elusive virus. And so, as Dr. Moss mentioned, it's been complicated to try to follow this. However, the vaccines have made a huge difference in terms of hospitalizations and deaths. So it has actually done quite a bit. Other issues coming from the community people, it sounds like, from the members of the CAG, there's a need to learn more of the science. And I think some of that is to rebuild trust. But also that many of our organizations need to know more of the science so they can teach others what's really going on. There's an emphasis, people are concerned about caregivers and how important it is to reach caregivers, even if they're not over 50, if they get COVID, it impacts, far more people than just the person themselves. They're taking care of often a vulnerable family or another somebody else. And so apparently there are questions among caregivers about whether or not they should get boosted as well. And some of this, one of the issues brought up last time is among younger people. I'd love to get feedback on this point, is if younger people, that the message about getting boosted in order to protect your family, if that's as effective or if that's an impactful message. Okay, so that's some of what you lifted up or that we heard. And then the other part, when we asked for ideas about how to increase uptake of boosters, a number of really good suggestions came forward. So some of this is putting forward real world examples, simplifying the message. We've heard this a lot, and that has been something, that's challenging. And also, in our messaging, to be realistic that boosters, they're clearly not going to end the pandemic, but they do help prevent serious illness, hospitalizations, and death. And then finally, that there was recommendations to target our marketing efforts specifically to the elderly, some of our more vulnerable populations, and including SSI workers and those receiving SSI. So I'm going to stop there. And I would love to hear back if folks would like to turn on their videos or raise your hands. Did we capture this correctly? Did we miss any important ideas, either about what your communities are saying or some ideas about how to increase booster uptake? So let me turn that over. And I can't see everyone, so I don't know, Lauren, if you could help if there's a hand raised.
Don't see any right now. I know it's a lot. People might be taking it in. If you want to give a moment.
Okay. Not seeing any hands jump to the front. So, and again, new ideas are welcome. You don't have to have been here last time to participate in this, but why don't we go to the next slide then? And, oh, great. Thank you. Thank you, Wendy. So this does a little affirmation is helpful. Yeah, if you have other thoughts, please feel free to put those in the chat as well. So the second breakout session that we did last month was focused on treatments, because we've been hearing there's a lot of confusion around treatments. So when we asked, what are you hearing from your communities, and what are their concerns, that clearly that treatment options are not widely understood. And there are several folks who mentioned that providers are not up to date. It seems like some providers have turned people away because of eligibility, and that it is, and sometimes it's really challenging to even get through to a provider. A lot of our messaging has been, go see your doctor if you get sick, if you have a positive COVID test. And not everyone can do that. Treatments are really most effective in the first 5 days if you start them early. So these are some serious challenges that we have. Some people are concerned about the side effects. They're worried if that's more, if those are worse than the disease itself. Folks lifted up that in the Latinx community that many don't know about the test to treat options, or especially seniors who may not be, I want to say digitally connected, but it's, through the internet, or have technology resources or access to technology, that a lot of our appointments and finding where the clinics are most easily available. Other issues, concerns about isolation, quarantine, and there's many folks who still don't have insurance, and because they don't have insurance, they're often deterred from seeking the vaccine or treatments. So those, I think, are the high level. We tried to summarize it. I boiled it down to a lot fewer, but we appreciate the feedback that we got. I think this is consistent with what we've heard also from staff working out in the community. Next slide. And similar to the last one, if there was a number of ideas that folks came up with when we asked how to help increase the uptake of therapeutics. And some folks mentioned that if we had a decision tree that makes it very clear if this, then that, so people know where to go, if, depending on how they answer. Others suggested arming people creating talking points. So when somebody who is COVID positive, or if they test positive, that they know how to talk to their providers and they can actually advocate for themselves if they want treatment. Other thing is using our communication tools to raise awareness about the availability of treatments among community providers. I know some time back they were not as available, and now they are actually. So how do we get the word out and help improve that? And finally, there's the need for delivery options for people with limited technology access. And we are looking at, we do have a homebound vaccination program. We're not sure in terms of treatment options. We're working on getting treatments more available to people who are not able to get out to a clinic. So those are being explored. So let me just stop there and again, see if anyone has thoughts. Did we capture this correctly? Are there other ideas that people have about access to treatments? Okay. Not seeing any hands. It is a quiet night, isn't it? So.
Oh, there's something in the chat, Julie.
Oh, good. Oh, thank you.
Wendy, I didn't know if you want to share out loud. If not, I'm happy to read it.
Yeah, no, it's fine. Yeah, I don't know why I'm typing so much. It is quiet night. So I'm hearing from a lot of people who know somebody who had a rebound infection after taking Paxlovid. And what I'm hearing people say is, if I'm going to get it twice, I think I'm not going to ask for Paxlovid because then I could just have it once. Maybe it'll be worse, but I could just have it once and not have to then have it again. So I think there's like a lot of information that needs to, there's an information gap about the rebound and Paxlovid.
Okay, that's good. Thank you for lifting that up. Yes, that is important, and that would change how we do the messaging, especially around treatments. Thank you, Wendy, for that. Are there other thoughts, feedback, suggestions?
I believe Dr. Rhodes has her hand up.
Dr. Rhodes, go ahead.
Yeah, I just want to respond to the issue of Paxlovid and rebound in terms of like what the messaging looks like, because first, it's not because of Paxlovid, and second, even with rebound, there is some really significant data suggesting that using Paxlovid actually reduces the risk of death by about 80%. So I feel like there's not a lot of information around like, why would you take Paxlovid besides sort of the simplistic off the top, it will shorten the course or reduce symptoms or whatever. But really, we need to be talking about the long-term downstream effects of COVID and how Paxlovid interferes with that process of developing long COVID and of course of death. And then also to really try to disconnect the idea of rebound from Paxlovid, because Paxlovid is not causing the rebound, or we don't have evidence, I should say, to support that is actually caused by Paxlovid.
Really good points. Thank you. And thanks for lifting that up here. I think in this forum, and those are, I think when we look at our messaging, looking at ways of how to incorporate that. And I hope others who are generating their own messages also can lift that up. It's something we can circulate maybe with our talking points when we do those.
I guess I'm sorry, I have a bit of a follow on, which is this idea that like everybody, you know, whoever is producing messaging, I think at this point, especially given what is coming for the winter, I know it's like previewed, I would hang a little more crepe than Dr. Moss, because we have no reason to believe that Paxlovid is mild, or that COVID is milder. If we look over the course of the different surges, and only comparing summer to summer and winter to winter, because there are two different characteristics to those surges, the number of deaths is not going down. The number of deaths is actually going up. So I wonder if there's any thought to, you know, what we're trying to do with Umoja is actually say, we're just going to own the messaging now, because it did, like, the most of the messaging is not centered around communities of color and communities who are disconnected from public health and healthcare, sort of created for people who have sort of average access to these different kinds of resources. So I'm just wondering if, you know, even with the coalitions that are on contract with the county, like, is there some consolidated way to really focus the messaging so that it does center the experiences that communities of color are going to have? Because as COVID surges, we know in this country, right, a third of the deaths are African-American people, even though we do not represent 30% of the population, right? So the messaging actually needs to be targeted and centered to the people who are going to, you know, bear the brunt of this next surge. It's not going to be any different than any other surge. So I'm just wondering, what's the thinking around, you know, you've got these community organizations under contract, going door to door, knocking on doors, talking to people. What are they carrying in their hands that provides a kind of information that I think you have listed here that was sort of requested, you know, by in the breakout groups, right? A roadmap to what you do if you get infected with COVID, how you would access Paxlovid in Alameda County. I think we need to formalize and make uniform those materials versus sort of saying, like, what are you going to say to your community and what are you going to say to your community? Because I don't think a lot of people who are talking about COVID and developing the messages have the kind of background and expertise to come up with the, you know, the fine talking points that help people understand that actually reduce your risk of death, right? That's not a natural thing that's going to come out of the messaging. So I'm just wondering, is there a, you know, is this meeting a place where we should actually actively be working on, let's look at a visual and then figure out what is the language that is compelling that should go with that visual, you know, while you've got this captive audience of community folks who are aware of what people are saying, right? And can bring that kind of knowledge to the table so that we can together create messages and collateral and materials that can be handed out by all of the coalitions across the county. That's just thought.
So yeah, no, thank you for that. And I think that's very helpful and very practical. We do have a group that meets every week on to look specifically at messaging and how to center that messaging more in the community. There are, and I know there's sometimes a few weeks back where they did have some sessions with the coalitions to look at, okay, here's the message, sort of the uniform message. How do we simplify it? How do we make this more relatable to people in different communities with some of the coalition partners? And then they worked on reshaping those so that you'd have the same message, but it could be told in different ways that would have meaning for people in communities. How much we formalize that or do that on a regular basis, it's something I could look into. And I don't know if Kimmy, if you have any thoughts on that, or it is something, and I think what you described is exactly right on, that we need to work in this, do this messaging and work in collaboration with our partners.
You know, so couple of things are happening. One is that our next CAG meeting is going to be devoted to health promotion, health education. How are we, you know, working together to talk about this? And we're hoping that we will have confirmed community partners who are working in the coalitions to talk about what's working for them, what's not working. And I know that just in some, you know, conversations, I think Dr. Rhodes, you have some really good ideas about ways in which partners can work with each other, with us all together, to develop, co-create messages and materials, that kind of thing, that we all know is going to really reach the population that we're talking about, that is going to be effective, you know, impactful, and that sort of thing. And so we definitely do need to improve in that area and really look for, you know, your ideas, Dr. Rhodes, in those spaces with the coalition to, you know, help kind of think about like, okay, how can all these coalitions kind of work together, and not do without us, with us convening, with us, you know, pulling people together and that sort of thing. But I know that you had some good thoughts about that.
Great. Yeah. And thank you. And thanks for sharing those, because that's exactly what we're looking for. I'm taking copious notes here. Go ahead. I'm sorry. Was there someone else who wanted to? Okay.
Julie, the only thing I would add to what Director Watkins-Tart has just laid out is that, you know, our experience over the last 2.5 years have really kind of reinforced for us in the health department that we really needed to kind of take a look internally at how we handle and manage, you know, create health promotion, health education messaging. And I think over the next few weeks, over the next few months, one of the things that Director Watkins-Tart and I will be doing is we will be putting together internal meetings to the health department with folks who have expertise in health education and health promotion, and to really solidify and to consolidate our health promotion, health education framework as a health department. It might help us as we engage community in conversations about how do we consolidate, how do we message together in a way that is consistent, that's in a way that's in evidence informed and community led. And so I think you'll start to see some of those changes, Dr. Rhodes.
Great. Thank you, Dr. Ayala. I appreciate adding that in, because we are doing, there's a lot of things happening internally as well, but and I think incorporating those ideas is really important. Okay, so is there any other feedback, any other thoughts, ideas people have related to treatments before I move on to the strategic refresh? Okay, well, if there are, feel free to add to the chat and we can pick those up later. So why don't we go to the next slide? And just let you know, so we've put this into a final format, and this is the 2-year strategic plan. And what I'm going to review is just sort of the high level what will be different. As we've gone over before, the strategic plan, we've retained the same 4 goals that we've had throughout the pandemic, which is really focusing first on prevention, and secondly on testing and treatments is our second main goal. The third main goal is to be equity focused, to make sure that we focus our resources on those communities that are most disproportionately impacted. And finally is to build our infrastructure. The last goal is really looking at how can we use this opportunity to sort of grow and build the infrastructure that's really necessary to manage events like this that happen in our community, to protect our community's health. So next slide. So just looking at some of our strategies, well, before I go into what we're going to be doing more of, there's a number of things as the pandemic has evolved. There's a number of services that we are discontinuing. In the very beginning, if many of you recall, we were doing universal case investigations. That means calling every single person that had a positive COVID test. We were no longer able to do that, especially with Omicron. And right now we're at a point of discontinuing the universal case investigations. We're now focusing our efforts more on outbreaks and complex cases. The contact tracing, again, with the numbers that we have right now, we're also finding that the virus spreads so quickly, it's not as impactful as it once was in the very beginning. And so we're no longer doing contact tracing unless it relates to a complex case. We have discontinued in the beginning, and again, when we had those huge surges last winter, we engaged a number of CBO partners to do case investigations and contact tracing. And so their work has been completed as cases have come down. We've discontinued the mass vaccination sites at the Coliseum and the fairgrounds. We're also reducing the stationary pods, and I'll show you what we're doing in place of that in a few minutes. And we've been, well, I'll talk about outbreaks in a minute, but we're not doing siloed outbreak management. So just focusing on one setting or another. And also just behind the scenes, what most of you don't see is our data migration. All of our work is focused in the data that we get. What used to have a manual migration system, but now we've automated that. So we are much more efficient in how we're moving data from one platform to the next and make it accessible for those who then post it to our website so we can keep track of what's happening. So those are the things that we are reducing or discontinuing. And if you could go to the next slide. Here's some of the things in the refresh, our focus moving forward now. And these are really just the changes. I wanted to show you sort of the table of contents before. We have a much more detailed strategic plan, but these are some of the high level changes. That our equity focus remains in place, and that's where we will be focusing on the impact of long COVID and of chronic conditions on those parts and members of our community that are disproportionately impacted. In terms of outreach and education, we want to continue and extend our support for the community resilience coalitions that you were just referring to, and the single organizations that are doing the outreach and education to reach unvaccinated and uninsured parts of our communities. We want to increase our community support team, and they're the ones who, when people call in or email us or contact us, that respond and work to link residents with the resources that are needed, regardless of what they are, whether it's housing or financial resources or health resources or other resources within the department. They serve as that linkage. And finally, our treatment, education, and outreach program we have started, and we're piloting. We continue to pilot. We call it TEO, but it's really for the cases that we see from the testing data, people who are over 50 that live in our priority zip codes. We're reaching out and contacting those people to see if they have heard of treatments, if they have access to them. And for those who are eligible and who want access, we link them up with resources so they can get direct access to treatments. Okay, with our outbreak investigations, we are focusing these more instead of all outbreaks, because many places that have experienced outbreaks in different settings, they now have the resources if they've been through it before. They understand how to manage those and prevent those in the future. We're focusing some of our efforts more on complex cases and also on treatment calls. We're increasing our focus on infection prevention. So this is really trying to work with different settings that are at high risk and make sure they understand and can put protocols in place for how to prevent transmission. We're providing technical assistance with outbreak management. And then internally in the health department, we're cross-training all of our outbreak teams so that we can respond more rapidly. If there are more outbreaks in long-term care facilities and fewer in other settings, we can redirect our resources, and vice versa. If there are fewer in long-term care, we can move people into some of the other settings, like youth congregate settings, correctional facilities, healthcare facilities, things like that. Okay, next slide. All right, so just in our vaccine program, which is really, this is our prevention strategies in our first goal area. We're focusing more now on in-home and pop-up points of dispensing, or pods as we call them. And we're working with our community resilience coalitions and organizations to reach into those parts of the community that we've not been able to reach or have not had access to vaccines in the past. We're focusing more now on boosters. We do have a high vaccination rate for first vaccinations, but there are still places, there are disparities that continue to exist. And so we're working with our partners to increase boosters and to get information out or co-locate these services with other health issues such as monkeypox. And I should take that back. We're co-locating COVID and flu resources. So you can get a flu and a COVID vaccine at the same place. But we're also trying to provide information about monkeypox and other common health issues in some of the communities that we're in at the same site. So it's not just a single focus. We're also supporting pediatric providers to vaccinate the 0 to 4-year-old group. And we're working more closely now with our health system partners to increase vaccination and booster coverage. So those are some of the vaccine strategies that we're increasing or where we're focusing our effort. And finally, our testing and treatment services, we're trying to link residents directly to treatment at testing sites. So we have more test to treat sites. We're building our own internal capacity for testing inside of our communicable disease division. And that's something we haven't had before. And I think COVID has really lifted up how important it is for us to be able to bring testing resources into underserved communities. We're providing test kits now and masks to our community partners to distribute to the community. Hopefully in anticipation of our winter surge, we're trying to get more and more of those out. And we're also linking underinsured and uninsured residents with telehealth resources. This is one of the ways we're helping to reach people who are more homebound or don't have access or aren't able to travel to a clinic. And finally, we are working with the health system to increase access to treatment services. So hoping to increase information among our providers so more providers are up to speed on what the requirements and eligibility is. So those are really the main changes that we're making to our strategic plan. And I want to just stop there and see if many of these changes we have put into place in response to the feedback that you've given. I really want to thank the CAG for all of the help that you've given in guiding us and in helping support the management of a really complex situation that we have with COVID. And I'd like to open the floor for any feedback, thoughts, questions.
Dr. Rhodes has her hand raised.
Dr. Rhodes.
Yeah, thanks. It strikes me that with there are 3 slides, but the first 2 kind of struck me about like what's being discontinued looks like, our efforts to mitigate are being severely reduced, right? Because in the second slide, the focus is going to shift to long COVID. And I'm extremely uneasy about the winter and what's coming, because look at Singapore right now. Look at Austria right now. The curves are pointed, they're nearly vertical. And because we have sort of given permission for everybody to not mask, which, is the final common pathway of the infection, right? Is your face. I'm just concerned that discontinuing the intensity of the upfront mitigation measures, including like kind of where, like how much testing is available, doesn't really jibe with, in the strategic refresh, trying to hook people to testing and settings where they can actually also get treatment. Like, though, to me, the structures that are being discontinued are the structures we're going to need in the winter in order for you to do your strategic refresh.
So, yeah.
So the stationary pod sites, and maybe that's about vaccination, but nonetheless, like, where is testing? Where is access to testing? that we're going to need as things start to ramp up? Is that if that goes to our health system partners, that's going to be a limitation. If I'm glad that we're building capacity in the public health department, but I also understand that the Valencia lab is reducing its capacity and volume. So I'm just saying there are these things that don't kind of match, like they match to the fact that we're in a dip right now in terms of the number of cases are coming down, but we know they're going to go back up, and we could probably predict the date if we just look at the full trajectory of where we've been in the pandemic. And I guess I'm having a hard time visualizing the how you will activate the number and volume of staff you're going to need when we hit this next winter surge, which is going to be exacerbated by the fact that people aren't wearing masks as much anymore. So we haven't even come down to our usual, 2% test positivity or 1% test positivity. Like we're going to start at 5. And I think people forget 5 is the level of the first winter surge when we were all completely freaked out. And actually a lot of people died because there were no vaccines, but we're at that same level, but we're acting like we're at 0. And so now we're going to shut down a lot of infrastructure. And I also understand, this is not against the department. I'm just really, I'm like afraid. And I have cried several times about what is coming for us, because I think we're acting like, oh, it's good that things are going down. We're saying things like it's milder. We're not emphasizing ventilation, clean air, measuring the ventilation in a room, having HEPA filters. We're not emphasizing the ways that we can continue to protect ourselves, even in the absence of the federal funding that is going to truncate the county funding that is going to reduce our ability to respond. And so I'm just not seeing the structures that are going to jump into action in the winter, to deal with the thousands of people that are going to be infected kind of all at once. So I'm just, maybe if someone could help me see the rapid response team, like, make it real for me, because the winter is going to be bad and we have no reason to believe it's going to be better than any winter we've seen before. And the last winter was pretty bad.
Okay. So I know that Julia's she's gonna say something, and others, George may also want to jump in, but I'll start by saying, so what is not reflected in the slides, unless you showed that part, is how we're phasing these things. And so we are not intending to discontinue, like a rapid discontinuance of like testing and all those things right in the middle of the winter kind of thing. And so we do know that there's going to be a surge. We don't know how big. And so we are really kind of holding steady in terms of the size of our operation, what we have in place, where we have contracts, that kind of thing. This is really just over the arc of like 2 years kind of thing. And I think that the slides don't provide the nuanced detail, Dr. Rhodes, that you're asking about in terms of when are you sunsetting these things and when not. And it kind of implies like we're sunsetting all this stuff like right now. And that's not correct. That is absolutely not correct. And so I know Donata's on as well. And, our goal is to get through, the next, definitely the winter, and Donata's way more eloquent about this in terms of the detailed plans. But we have to get through a couple more surges with everything, all of the mandates gone, to really kind of see, what's going to happen. So we're not comfortable either, Dr. Rose, with the situation that we're in. We're not comfortable with the fact that people think that COVID is over. And we all know that it's not. We're not comfortable with the fact that a lot of the resources are drying up at a time when we can least afford them to be drying up. And so we are trying our best to use whatever resources we have to keep things cobbled together through this next period kind of thing. So Donata, like I said, I know Donata and Julie, you all have dates and, and the thing. in that, Dr. Rhodes, you're kind of alluding to.
Yeah, I mean, I can just add that exactly what you were saying, Kimmy, that, you know, we're planning to start to ramp down after this fall winter surge. We're continuing our testing contracts. What Julie was saying about, you know, really being more nimble operations. So we're cross-training our staff so we can pivot to wherever the resources are needed. Our treatment education outreach calls are actually 2 cases. So we're not doing case investigation where we're telling people, you know, the traditional way we used to do, where we, you know, please make sure to isolate and you have to stay home for these many days. We're really more focused on making sure they have access to treatment because our county is so highly vaccinated. Overall, I know there's still pockets where we're trying to coordinate with our HPCP partners to make sure there's, you know, those pop-up clinics. But I think we're just becoming more nimble and really putting the resources where they're needed. And we will be continuing through the fall and winter surge with our services.
Right. And yeah, I should just add that, you know, with a lot of these slides, when I presented, we often go, there's a lot of areas where we're increasing our focus and our resources. But to do that, we do have to decrease and stop some other things. And I sort of did it the reverse this time, and it might have set sort of the wrong impression. We're not reducing our operations. Many of these things have been discontinued for a while. And as Donata said, part of this is so we can be more nimble and focus those resources in the places really that are being hit the hardest by this disease.
Can I add one more thing, Julie, about the nimbleness? A part of the other nimbleness, and I think that it is alluded to in the slide here, is one of the slides that as a department, we have to be able to, because right now, as you all know, because everything's open. So we are running all of our regular programs full scale like we were before. And we have a very large COVID division still, you know, working on COVID. And we also have to have in place enough infrastructure as time goes on and as we ramp down slowly beyond the winter surge, so that we have the ability to flex up more rapidly than we were able to do when this all started. We don't want to go back to where we were when we started with COVID. We want to land in a place where we are stronger than we were before, and we're able to scale up rapidly. And so, because we can't stay at this heightened state consistently, but we do know that we don't think that surges are going to stop happening. And so really, we have to be able to flex up and flex down, flex up and down much more quickly than we did in the past, and be able to flex up a lot for a lot of cases, for a lot of things that are going on. So that's our goal. That's what we're trying to accomplish, you know, with all of this. And so, but we are absolutely as concerned as you are about this.
Let's see. George, did you have anything you wanted to add? I just saw that you came on screen. Is there?
Yeah, I mean, I think maybe a topic for another night with the CAG is some of the behind the scenes work that I think Kimmy has been alluding to, which really involves, you know, some of the reorganization that's happening, some of the training, workforce development that's been happening. All the lessons learned from our experience with COVID has given us an opportunity to take a hard and deep look at, you know, the public health department. And we've been making changes, and we don't talk about it often enough, or we haven't been public enough about those. We've been talking about our COVID response and our COVID division. And while we've kind of made adjustments to our COVID response, at the same time, running in parallel are all these other changes that have been taking place in the background. And at some point, we'd love to share that too, because it really is a response from my perspective to the lessons learned from COVID from a public health perspective.
Great, thank you. Okay, thank you for that. And I appreciate, I think, the comments and the concerns. And actually that would be, I think it would be helpful to bring forward sort of a larger department-wide perspective of how this really has shaped how we're moving forward. Let me just ask, are there any other thoughts? I know we're reaching the end of our time. That's all I have to present. And so maybe I can turn it back to Nestor or Director Watkins-Tart.
Yes, I think I'm doing the closing.
Okay.
So thank you, everyone. And just want to comment, you all were very quiet tonight. Thank you, Dr. Rhodes, for your questions. We appreciated them. So one of the things we wanted to ask, so we're scheduled for our next meeting November 8th. And so wondering how people feel about still meeting, or are people going to be engaged in last minute, outreach activities, helping people to get to polls, helping people turn in their stuff. I don't know what people do, in this group on election day. And so wanting to know if people want to still meet on the day on November 8th as planned, or do we want to change the date? And so if some of you could come off camera and just say something, throw it in the chat so that we can get a sense of how you'd like to proceed for next month, we'd appreciate that. I'm not hearing anything. I only heard from Wendy Peterson. Okay, you guys are really quiet. Okay.
Maybe we could do the online poll or the email poll.
Okay, yeah, maybe we can do it that way. Okay, well, we are still open to hearing how you think about the November 8th. We will make a decision about that. Keep in mind, we may very possibly change the date. So please note that it may change if we start hearing from people who have plans on election day to be engaged in other activities. We don't want to compete with that. So thank you again for your participation, and good night.
Right. Thank you.
Thanks all. Thank you to our interpreters. Thank you to our other presenters. Thank you for our mobilizers as well. Yeah, that was really, really thoughtful. All right, I'll close this out.